Session 19, disorders of the pancreas. And before we go on, the session covers the pancreas and its major functions. The major disorders of the pancreas, such as diabetes mellitus, is discussed. And so at the end of the session, the student should be able to indicate the role of pancreas in the regulation of blood sugar, and then describe the three major types of diabetes. Identify patients with clinical manifestations of diabetes mellitus. Describe treatment protocols available for the treatment of patients living with this condition. And identify coping styles used by these individuals with diabetes mellitus. So here, the key topic to be covered in the session is diabetes mellitus. Diabetes mellitus is a chronic and potentially disabling disease characterized by elevated levels of blood sugar. And then diabetes causes alterations in metabolism of carbohydrates, proteins, and then the fats. And it's a major condition that affects most Ghanaians. And then we have, it's one of the non-communicable diseases. And so carbohydrates are the body's preferred source of energy, and then once digested, carbohydrates are converted into glucose and then provide necessary nutrients for the body. So through careful release of insulin, the body is able to control how and when fats, proteins, and then carbohydrates are metabolized. And so insulin is released continuously by the pancreas according to the needs of the body. Diabetes classification, we have type 1 diabetes, and type 1 diabetes, formerly it was known as insulin dependent diabetes, IDDM. And so in type 1, genetic or viruses or autoimmune response alone or in combination are involved. About 5 to 10% of people with diabetes have type 1, and then most people with this condition are diagnosed before they attain the age of 30 years, and there is inadequate supply of insulin in this type. So patients who are diagnosed as having this condition need exogenous or external type of insulin. So type 1 diabetes results from destruction of the beta cells in the islets of Langerhans in the pancreas. And so the destruction usually results from immunological defects that produce antibodies against the beta cells. And these antibodies may be present for months or years before clinical symptoms of diabetes actually develop. And so what we know is that research with a human leukocyte antigen, HLA, systems, which is used in the tissue typing, has demonstrated or shown that there is a relationship between some HLA antigens and then diabetes. Some of these antigens are consistently identified and then found in insulin-dependent diabetes mellitus patients. In other words, we are looking at type 1. An example are DQ, DAQ, and then B genes. And some researchers have also observed a relationship between various HLA antigens and persons with long-term complications of diabetes. However, not all persons with these antigens develop diabetes mellitus type 1. And so that question is still hanging. But we have the viral factor. Environmental factors such as virus may also act to trigger the autoimmune response. And so the genetic makeup of cells in an individual probably determine whether the virus can attach itself to the cell surface and then enter the cell and then change its metabolism in the individuals. So the characteristic appearance of insulin-dependent diabetes could be a result of an infection with a diabetogenic virus in a person already genetically predisposed, and that the infection might cause an autoimmune reaction or antigen-antibody reaction in the individual. In order for insulin-dependent diabetes type 1 to develop, we know that at least 90% of the individual's beta cells must stop working or must stop producing insulin, and this usually results from one very potent viral attack, or it could be the result of a series of viral infections that eventually destroy the beta cells. We also know that antibodies against one of the suspected virus, contd B, have been found in the blood of patients who have just been diagnosed as new patients with having insulin-dependent diabetes and not in non-insulin-dependent diabetics. All along that we have stated, we as showing that there is a possibility of virus implicated in the cause of this kind of condition. There is an evidence. So evidence that suggests a viral cause for insulin dependent diabetes type 1 include the following. It usually occurs in young people whose systems are more prone to viral infections, which is true. And it also occurs suddenly, like any viral infection. And it usually occurs when viral infections are prevalent, and that is specifically. So beta cells are inflamed early in the viral infection, and the viral infection may develop before the diabetes develop, and that can be obtained from health history of the patient who is affected. And so it may develop in a child with no family history of diabetes mellitus as well. Although the exact mechanism of inheritance has not been identified, we also know that blood relatives or known patients with diabetes should maintain lifelong vigilance for this condition, because it can occur in this way. And obese persons and mothers who have delivered babies who are large or with increased in weight are also susceptible, and these high-risk individuals should be examined regularly for signs of diabetes. And most of the chronic conditions such as diabetes 1 and 2 are explained using naturalistic and then personalistic and then emotionalistic disease causations. Probably later you can take your time and then go through some of this. The naturalistic and then the personalistic and the emotionalistic factors are some models that are used. So far we have focused on our attention on the naturalistic, which is the scientific mode or model for the description or explaining the causes of this condition. Nevertheless, you should also consider reading the other two models of illness causality by Kotak 2014 in order to offer appropriate care to people with diverse cultural and ethnic backgrounds, because other people think that personalistic factors and then emotionalistic factors are taken into consideration when it comes to disease theory explanation for explaining diseases, how they are developed. Clinical manifestations, we have when diagnosed individuals have these four clinical cardinal manifestations. We have weight loss or muscular weight due to breakdown of protein and then lipids. We also have frequent urination, and then we also have excessive thirst and eat excessively, which is polyphagia, and extreme hunger. And then in addition, it usually begins in childhood but may occur at any age, and the measurable circulating insulin may also be present. And then as insulin production decreases, hyperglycemia develops as a result of the body's inability to use the glucose. So if the concentration of the glucose in the blood is sufficiently high, the kidney may not be able to reabsorb all of the filtered glucose. So the glucose then appears in urine, and that is where we have glucosuria. So fluid loss through the kidney results as the kidneys work to excrete the increased load of glucose, and then production of loss of water, sodium, and then magnesium, calcium, and then potassium chloride, and then phosphate. So in summary, in type it develops in 5 stages, we mean the type 1. We have the genetic predisposition, we have environmental trigger, we have active autoimmunity, and then we also have progressive beta dysfunction, and then we can also get the overt disease, which is the diabetes mellitus, whereby we have clinical manifestations. I want you to look at ketoacidosis yourself, and that you can take your readings, and the courses we have provided. We have the clinical manifestations also associated with the ketoacidosis, which is not similar from the other major manifestations that we have already identified. Complications are also there. Complications, you can, over a period, blood glucose levels that are consistently above normal appears to cause complications that affect the large vessels in the kidney. In the kidney, we have the brain, we have the heart, and the extremities, and small vessels in the eye, kidneys, and then the nerves. Type 2, which is type 2 diabetes, we have the other name. The old name is the non-insulin dependent diabetes, and in type 2, genetics and obesity play a more significant role. But the exact role that heredity and obesity play is not yet completely understood, though they contribute, and there's apparent no relationship between viruses and then etiology of the non-insulin dependent type 2 diabetes. It also results from a decrease in the amount of insulin produced, and when we look at the patients who are diagnosed, we have about 90 to 95% of people with diabetes have type 2, and the individual have onset after age of 40 years, and the classic symptoms are not present when the condition is first diagnosed. So in some non-insulin dependent diabetes persons, insulin secretion is increased, resulting in higher circulating insulin levels. Although excessive insulin is present, it is not utilized because of an inadequate number of insulin receptors present in insulin in the cells. Okay, let us note that being treated with insulin supplement does not change the classification of type 2 to type 1. So there are some people who may have the type 2, and then we may treat them with insulin. So in general, or in practice, the patients may never require insulin and are usually managed adequately with diet, and then the majority, about 8% of the non-insulin dependent patients are overweight and when the condition is first diagnosed. And symptoms may also be minor, that means disease is undetected for many years, and the diagnosis may be made suspected or as a result of routine urinalysis or during presentation of another condition like hypertension, and then, for instance, when one goes to the hospital for screening. And then frequently the disease is discovered when the patient seeks health care treatment of complications such as deterioration, vision, pain, and then legs or impotence. And then often blood glucose tests are normal, and then onset is insidious. Read on HONC, which is a hyperosmolar non-ketotic acidosis in type 2 diabetes. And you have to differentiate this from ketoacidosis in type 1. Diagnosis based on classic symptoms, which are polyuria, polydipsia, polyphagia, and then rapid overweight, and then elevated fasting blood sugar level is also very important. And then we can also do other investigations, and then we can also use glycosylated hemoglobin tests. We can also do other tests. The other type is the gestational type, which is also common in people who when become pregnant. So GDM, which is the gestational diabetes, applies only to women in whom glucose intolerance develops or discovered during pregnancy. So after pregnancy, diagnostic classification may be changed to either IDDM or NIDDM. So women who had a disease before the pregnancy are not included in this classification or category. And so women with GDM have an increased future risk for progression to NIDDM or really IDDM, and what are the possible causes. Effects of pregnancy. So during pregnancy, pregnancy is said to be diabetogenic due to increased production of insulin antagonists such as human placental lactogen, placenta insulins, cortisol, estrogen, and then progesterone. So insulin requirements increases during pregnancy and due to increased production of insulin antagonists, while it decreases postpartum. Other types, we have the impaired glucose tolerance, which we can read later, and the secondary DM as a result of other disorders. And then the management of DM or diabetes, we have the therapeutic objectives. Objectives of long-term diabetes treatment are to relieve symptoms and maintain fasting between days 4 to 6, and then 2 hour post meal from about 4 to 8 millimoles per liter, and then prevent acute diabetes complications, and then prevent chronic complications of diabetes, and then to achieve glycated hemoglobin of 6.5%, and then other factors. We have management in terms of medication. We have the injection insulin, and then we have oral medication. The oral medication, we have the banguanase. Examples are metformin, and then we have the C, which is the sulfonylureas, and then here examples are tobutamide. We have the glycoside, and then we have the clibeneclamide, and then others that are also we have the tazolidinions, and then here examples are pioglitazones and then rosiglitazones, and we have the recommended dosage or based on the doctor's prescription. And then we have the combined therapy, individuals with type 2 diabetes not responding to maximum tolerable dosage of sulfonylureas or metformin or tazolidinios are also put on combined oral therapy with 2 or 3 oral anti-diabetic medications. However, 2 different products from the same groups, for instance, 2 sulfonylureas should never be given to a patient. And for oral hypoglycemic medications, we have to know that patients who usually have type 2 diabetes, diet alone should be tried at first, and then we can also combine diet with exercises, and by when this fails, then we can move on to oral medication. And the non-pharmacological treatment, we have the diet plan, which is very important, and the exercise is very important. So benefits of exercises, we have improved insulin sensitivity, lowers blood glucose, assists with weight loss, and then prevent preserve with cardiovascular fitness, and then improves sense of well-being. So exercises is very good, and then everybody should be involved, including even those who are not. By exercises, we should be able to look at frequency, intensity, and time. And so for effective activity or exercises in the management of diabetes mellitus, we have to consider the time that we do it, the frequency, and then the intensity. And here, as we do it, we should also consider comorbid conditions. If the patient has other conditions which will not permit him or her to do exercises, we should be cautious of that. So risk of exercises is hypoglycemia, which is a diabetic emergency. I want you to look at that. And then also monitoring, for example, monitoring the blood glucose levels using daily scales. For instance, you can use the sliding scale, which you need to look at it. And so self-monitoring and the use of diary to record daytime and the monitoring results by the use of glucose, a glucometer, and the test strips is very important, and that will help you to be able to adjust either whether to increase the number of hours that you do exercises and the type of food that you eat, or even the type of drug that you are taking, whether it's working or not. So diary is very important to do the recording of results. Okay, so education in general is also very important. Nursing management points at the myths about the disease, which must be dispelled through education. And then health history, psychosocial, and the emotional status is also based on that. Physical examination, patient education, insulin self-administration, we have to look at that. And then promoting adequate nutrition, managing medication, and then decreasing fear. And then complication, we have the micro and the macro. The micro disease, vascular complications is affecting small blood vessels, capillaries, and then precapillaries, arterioles. And the macrovascular usually affect the large vessels. So the microvascular diseases as a complication, the most common chronic complications we include the retinopathy. We have the eye, nephropathy, the kidneys, and then the neuropathy, the nerves. So the main degree degenerative changes in the diabetes occur because of a thickening of the capillary basement membrane. You have to read on this. And then the macrovascular diseases. Here we look at the coronary heart diseases. Usually these individuals suffer from CAD, tend to be overweight, and then often have hypertension and then hyperlipidemia. And these risk factors are particularly evident in persons with type 2 diabetes. We also have hypertension and the hyperlipidemia. We also have diabetic foot persons. Read on this, which are prone to foot problems for a number of reasons. Other complications, look at the skin disorders, frequent infections, reduced blood circulation in vessels of the skin. And then we also have oral complications. And then you have to read on prevention of the condition. And then exercises, weight control, which are very important. Knowledge of the risk factors, choice of diet, and the preparation are all very important. And then one most important is secondary prevention of type 1 and 2. Treatment at the hospital is very important, and that is based on 3 R's here: reporting early, when we are able to do right diagnosis, and then also commence right treatment, and to avoid healer shopping. These are the major things that we need to do when we are treating, looking at the diabetes. So as part of our education to the general public, what we need to do is that we need to inform them about the need to report early, especially when one has manifestations, and then when they are able to report early, then it will help the provider or the healthcare provider to do right diagnosis, and then also commence right treatment. And then tertiary prevention, the aim is to prevent complications based on early detection of signs and symptoms of complications. And then the major emphasis of the tertiary preventive education will be on the ability of the nurse to counsel the patient about the early detection of the interventions for the complications. And that is a patient empowerment, which is very important. Diabetes screening is very important. So fasting blood sugar screening should be at age 30 and 45, and then be repeated at every 3 years. And earlier or more frequent screening should be conducted in the risk individuals, especially where the family members have it. So family history will point to this. Overweight people should do this, and then history of gestational diabetes or infants born with birth weight greater than 4 kilograms, and then those with high cholesterol level. These are the candidates who need screening. And then high risk ethnic groups, hypertension, and then high fasting blood sugar level values at particular point in time, and then other factors we need to take into consideration. I want you to look at the Somogyi effect and the Down phenomenon. I've provided notes for Somogyi effect. As you read, you should be able to identify the difference between Somogyi effect and then the Down phenomenon. And these are very important, and they have clinical importance in the management of patients with type 1 and then type 2 diabetes. And I've provided the difference between Somogyi effect and then the Down phenomenon. As you're able to do that, that will help you. I've also provided insulin therapy regimen with different types of insulin that we have, and then how we are supposed to. But the most important thing is that for each of the insulin, they have the onset time and they have the duration, how many hours the potency goes down, and so the duration is very important, and that helps us to make a choice in terms of treatment. And then in the acute phase, it is also very important to look at the duration, and then when the condition is stabilized, then we also note the type of the insulin that we are supposed to. So I've given you the types, and then I've given you the types of the insulin, and then we also included is the kinetics. So we have the types, and an example of types of injection, 3 injections per day. We have multi-dose injection, and then injection sites, and then routes of administration. You have to read on this. Subcutaneous IV is preferred for patients having ketoacidosis, and the intraperitoneal for implantable insulin devices. AM may also be given. And they read on signs and symptoms of hypoglycemia and its management. And then I have sample question here. Probably you can try your hands on. For instance, effective use of standardized protocol for the management of diabetes mellitus is a predictor of a better glycated hemoglobin level, HA1C or A1C. Discuss. And the plan of answer this question is you have to look at the medication, you have to look at the diet monitoring and the exercise education, and then link with the concept of A1C or HbA1c results, normal values, in individuals with the diabetes mellitus. Another question is, what is the link between coping strategies utilized by newly diagnosed patients with type 2 diabetes mellitus and then their levels of HbA1c? And the plan of action is look at the positive coping methods, and then look at the negative coping methods, and then link this with anticipated HbA1c results for the 2 extremes. For instance, somebody with positive coping methods who goes to the clinic every day to do review, or somebody who does not stop taking the medication, who is very conscious about taking the medication and using all the medical coping strategies, who accepts the condition, who is not adamant about the condition, is likely to have good HbA1c results. On the other hand, somebody with negative coping methods, who is always found at the shrine, who is always found at the probably at other places, who does not take medication, and then that person has his own concept about the disease, associating the condition with witches and other factors, is likely to have the HbA1c results very bad. And so this is how we have to look at it. And then another question is, achievement and the maintenance of metabolic control in diabetes requires the judicious use of medication, diet monitoring, exercise and education. Discuss. And this is pointing to the fact that these are the major factors that we take into consideration to manage diabetes. Medication is very important, diet is very important, monitoring of the results is very important, exercises is very important, and education in general is very important. So these are the 5 major factors taken into consideration to be able to manage and to be able to achieve and maintain metabolic control of the glucose levels. Then we have to use these 5 levels. So another sample question for patients with HbA1c. I've given you notes indicating the normal levels of HbA1c between 4 to 6. And so as you do this, you should be able to understand in general principle how to manage the condition. I have references for you. You have to look at it and build on the knowledge that you have. Thank you very much.